Today I'm going to chat with you about a very relevant topic today, which is trying to avoid unnecessary treatment or over-treatment of the small renal mass. We're going to go through a couple slides about both issues, and then we'll take some questions from the viewers at home. So prior to kind of the current era, there has been a very different way that kidney tumors would present. In the 1980s, or prior to that, we would call these the internist tumor, when basically patients would present with very subtle symptoms, such as, maybe some pain, having an abdominal mass that the primary care doctor could feel, or having some blood in the urine, or very subtle things like fevers, chills, and it was really reliant on a very astute clinician to kind of put two and two together. The patient may have a renal tumor. Now, from 1980 on, we've been finding a lot of these incidental renal tumors. People walk into the ER, they get chest pain, they get scanned, and lo and behold, it goes down to their kidneys, and you see a small little tumor. So unfortunately, or fortunately for some individuals, we find a lot of these small asymptomatic tumors that may have never been destined to cause any harm, but we treat them as if they are all lethal tumors and need really aggressive treatment. So the reason why we're finding more and more kidney tumors, 4 times more tumors today than ever before, is because the widespread availability of scanning, CT scans, MRIs, and while these are obviously causing a lot of increased costs, increased radiation exposure, we're finding things which may have never needed to be identified and or treated. So if you see, these are not incidental or asymptomatic gigantic tumors which are being found. Basically, we are finding more of these small renal tumors, 2 to 4 centimeters. And when you find them, the question is what to do. Because we're finding so many of these small tumors, now the majority of patients have stage 1 disease. It's now almost 70% of patients who are found have stage 1 disease. And you might say, well, we're finding these patients often, we're doing 4 times more kidney surgeries today than the 1970s or 80s, and that would translate to less people dying each year of kidney cancer, and that is absolutely not what we see. We're doing 4 times more surgery, the same number of people die each year of kidney cancer. And that leads us to believe many of these patients were never destined to have harm from their kidney tumors. And what can we do to avoid every patient getting aggressive treatment? This is the same day I operated on these 2 individuals. One had a real classic kidney tumor. This is a 15-centimeter ruler. This was a giant tumor. We took this out minimally invasively. Okay? This was the average tumor we saw previously in that prior era. Later in the day, I took out this tiny little tumor, 1.5 centimeters. Now 65 to 75% of patients today present with these small, tiny tumors that we really incidentally detect. So treatment options for 2018 and now soon to be 2019, you find a small tumor like this, well, what to do? Could you maybe watch it and not do anything? Could you do a partial nephrectomy, shave off the tumor from the normal kidney? Can you do a radical nephrectomy, remove the whole entire kidney, or a procedure which I do with our radiologist, stick a needle into the tumor and freeze it or to locally destroy it? The problem is when you go into a surgeon's office, if all you have is a hammer, everything looks like a nail, okay? And majority of these patients do get aggressive treatment for their kidney tumor, okay? And that leads us to the first really discussion is basically unnecessary treatment. So I'm going to give you an index case. These are patients who I've treated. Names are changed. This is an individual, a 72-year-old female. She had chest pain. She got scanned of her chest, and lo and behold, the very bottom of the scan, a small renal tumor is found. The radiologist read this as a tumor, 2.4 centimeters, consistent with renal cell carcinoma. Remember, this is just a mass until proven otherwise. This patient has some comorbidities, controlled diabetes, hypertension, has some reflux, not that dissimilar to a lot of patients who are 72. She goes to see a general urologist, says, oh, I can do this. I'm going to be able to cut it out because it is potentially a cancer. So this individual goes under the knife, has a partial nephrectomy. The surgeon comes out and says, oh, we got it all. Congratulations. You're going to be cured. Okay? Well, this patient got admitted for nausea and vomiting. The kidney function slightly worsened. Kidney function is very important. And then the patient takes 3 or 4 months to come back to their baseline. The pathology comes back, lo and behold, they did get it all. Congratulations, you are cured of a benign tumor, known as an oncocytoma. Okay? Is this a success story? I would argue it's not a success story. Okay? And if you look, this is our data about to be published in urologic oncology. This happens not infrequently. 8% of the operations done in the United States are for tumors that are benign, meaning these tumors really posed no threat to a patient's overall health and well-being. And unfortunately, many of these lead to removal of the whole kidney. There's obviously, we have a healthcare crisis today with billions and billions of dollars of treatment being performed in the United States. If you look at the cost each year from removing these benign tumors, which is in the blue, okay, there's about $150 million of benign tumors that are removed each year. And you know how much grant funding we have to study benign tumors? Actually, zero. There's no NIH dollars allocated to the study of maybe finding these tumors and preventing unnecessary treatment. And so was surgery necessary? Was it avoidable? That is an area that I am doing research on, and it's something which I think we need to move the field forward. So we use these tools in our clinic. Obviously, it takes some time, but we have these available, and we do this on every patient we see. If you looked at this patient, you could say, well, a female, no symptoms, no smoking, here's the size, here's her age. It actually had a chance of being cancer only 71%. So just knowing nothing about Ms. Smith, I could say that 1 in 3 of these patients, like Ms. Smith, is going to have a benign tumor. Okay? So benign tumors rarely cause symptoms. We don't remove them because we're afraid they're going to change. We don't remove them because we're afraid they're going to cause local harm to the surrounding tissue. And if you look at it each year, 1,500 and 1,800 radical and partial nephrectomies are done each year for a benign tumor, such as what Ms. Smith had. And this average hospital stay, 4 days. 1 in 500 individuals, no matter how great a surgeon you are, there are complications that can happen. 1 in 500 individuals may die of their kidney cancer operation for an unnecessary tumor, okay, that did not need to be removed. So you cannot understate the complications, the lower kidney function, and the lost wages from recovery for removal of a benign tumor. Next, we'll move to overtreatment, which is really the overtreatment of an indolent or really wimpy, as I like to call, renal tumor. So here's another index patient. This is a patient, 82-year-old male, who had constipation for 2 months. The primary care doctor evaluates, does an exam, says, oh, let's scan you. Lo and behold, a tiny 1.8 centimeter renal tumor, consistent with renal cell carcinoma. Again, I hate that term because nothing is consistent with anything. It is a mass until proven otherwise, okay? And this patient does have some higher comorbidities, prior MI, prior heart attack, having high blood pressure, diverticulitis. This patient has a motor scooter to get around. Okay, goes to see a urologist who says, I have a fancy tool, the Da Vinci robot. I can offer you a minimally invasive way to do this operation. And they recommend immediate treatment. Okay, Mr. Gordon goes through surgery. The doctor comes out, I got it all. Congratulations, you're going to be cured. Okay, well, this patient was off their aspirin. They have chest pain, and lo and behold, you check, they have actually a heart attack. Okay, the patient goes to the catheter, a cardiac cath lab, gets 2 stents, and they're initiated on platelet therapy. The platelet therapy makes their blood thin, they bleed. They need transfusions. It takes several months for them to recover, to get back on that motor scooter and live their normal type of lifestyle. The path comes back, a very low grade, localized renal tumor. Okay, and this may have been in there for 10 or 20 years. There's some data that many of these, really the seeds or the initiating event is 30 or 40 years before This patient was not being harmed by this tumor. Is this over-treatment? Well, is this a success story? I would say it's not a success story, okay, because this patient probably didn't need to have treatment. So the majority of patients diagnosed with kidney tumors were really never destined to die of kidney cancer. It's very different if you find a small tumor in a 40-year-old person versus someone in their 70s or 80s who have some comorbidities. Many of these small tumors really have limited aggressiveness, okay? And most patients are treated like this is a lethal tumor which must be aggressively managed, okay? So really, this is the current treatment paradigm. You have a small tumor localized to the kidney. We think it's suspicious for cancer. We kind of scare you into saying it must be removed, and lo and behold, you go for a surgical intervention, okay? But why are all these tumors treated like they're highly aggressive when we know almost 90% of these small tumors will either be benign or indolent, okay? So most urologists will tell you that a complete removal of the kidney, or what we call a radical nephrectomy, okay, where you remove the whole entire kidney and the surrounding kind of connective tissue, we call that a radical nephrectomy. We consider that over-treatment. A lot of urologists say the gold standard is a partial nephrectomy, where you go in and you remove the mass like a lumpectomy for a woman who has maybe a breast lesion, okay? The urology community has called this the gold standard. But what I would oppose is Mr. Gordon's treatment the gold standard. Did he actually need anything? Or really should the gold standard be doing nothing for patients with indolent tumors and really offering treatment for those who really need it? That's what I would argue, okay? So all forms of therapy can have complications. Partial nephrectomy, which some urologists will say is the gold standard, you know, you can leak urine from the kidney after partial nephrectomy and need tubes or drains. You could have bleeding after partial nephrectomy. And I can tell you, I've done hundreds of partial nephrectomies with the Da Vinci robot, very complicated cases. I love operating. But in everybody's hands, no matter how good you are, patients can have medical complications, and we also can have surgical complications. These can be minimized with a very good surgical team. But one way to avoid those complications is to avoid treatment altogether if you can. Okay, so I'd say all forms of therapy in the kidney, they can lower kidney function. Some are potentially less harmful than a radical nephrectomy, but I'd argue that partial nephrectomy really is not the gold standard. Okay, now if I want to look at Mr. Gordon, what would I have known in my clinic about this tumor based on his age, his sex, the tumor characteristics? We would say that 72% chance that this is cancer, 28% it was benign. But if it was cancer, like his was, what is the chance that it was going to be an aggressive cancer? Well, only 16%. So 5 of 6 people were going to have treatment, and probably the tumor was going to be incredibly indolent. Okay? And an 82-year-old man with a prior heart attack, you might say, well, maybe he would die of something else. Well, you can actually counsel a patient with the 82-year-old white male with a 1.8 centimeter renal tumor. You enter his comorbidities. What is his chance of dying of something else in the next 5 years? Well, actually 45%. So over half of patients like this individual will die in 5 years of something else. What is if you left it alone? Really, what's the chance of dying of kidney cancer, whether it would be lethal or whether it be indolent? Really only 2%. Okay? And I'd argue that it would be less if you watch it and then offer intervention if needed. Okay? So now, what about non-treatment strategies? Well, not all cancers need to be treated. CLL, or chronic lymphocytic leukemia, low-grade prostate cancer, those we have no problem watching. Okay? But what if we don't treat? Well, most of my peers have no issue not operating on someone who's incredibly sick. So if you look at literature which shows what happens to these small tumors that really, that urologists say, I don't want to touch that patient, they're too sick. The actual size of the tumor over time rarely grows at a rapid rate. So the rate of spread is only 1.1 centimeters for patients who were never candidates for treatment. And I'd argue if you watch the patient, you can easily lower this by intervening if you're concerned the tumor starts to grow. So when you follow patients like I do a lot in my practice, when I can try to convince someone that really we don't need to hit their tumor with a weapon of mass destruction, you actually see some patterns. You have some tumors that are going to act like a shark. Okay? I don't want to swim with a shark. This is going to be very aggressive. There are other tumors that are going to act like a guppy, okay? A little fish that's not going to bite you, it's not going to cause any harm. And these are generally the wimpy or benign tumors. There's another pattern we see, which tumors slowly grow and may eventually cause a problem. And in a 45-year-old individual, those are clearly going to need treatment. But in a 70 or 80-year-old individual, potentially they're going to die of something else. So when we see patients, okay, this is my kind of hope for the future on where I am pushing the field forward, is when we see a patient, we have tools such as molecular imaging, genomic biopsy, and we can risk stratify patients, and then we can tailor treatment to the aggressiveness of the tumor. Not treat every tumor like they need to be treated like a lethal tumor. Okay? And we have ability now with just looking at the tumor morphology to do that, and we have molecular tools that are able to help me make a decision to tailor intensity. Okay? So I would tell you, well, first, before you start thinking, well, should I leave my tumor alone, find someone you trust that is comfortable offering all treatment options. Really understand the option, well, how can I prove that it is a tumor? We'll consider a biopsy, which we'll talk about, and really understanding some of these new novel tools that are available. So if you're going to call a carpenter, you're going to want to see someone with a lot of tools in their tool belt and not just a hammer. Okay? So if you find someone you trust, they can offer you all the available treatment options. Traditionally, 100% certainty that something is a benign tumor is lacking in our field. Okay? We're not at 100% certainty, but we have other tools which are near that now, which we'll go into. Urologists have generally proceeded to treatment, avoiding things like a biopsy because we don't have a reliable tool that gives you 100% certainty. Okay? But I'd argue that what other field do we actually do a radical procedure, a major operation on an organ, without really having a tissue diagnosis? Okay? I don't know a single man with prostate cancer who would let me take his prostate out if I didn't have any tissue to say you had prostate cancer. I don't know a single woman who would allow us to do a mastectomy without a tissue diagnosis saying that you have breast cancer. But for some reason, we've accepted this in kidney cancer. So biopsies historically have not been done. Most urologists say, I will only biopsy for metastatic disease or if there's concern if you have a lymphoma. Okay? The concern of a needle coming out of the body and shedding cancer, that does not happen. There's one report in the history of the literature in the past like 10, 20 years that someone says that could have happened. So we do not think that happens at all routinely. Okay? Bleeding or injury with the needle, that doesn't happen very often. Less than 1 in 100 individuals would have any really concern about anything like that. And the performance is great. If it comes back cancer, it's going to be cancer nearly 100% of the time. Okay? A negative non-diagnostic biopsy is going to be 15%. Okay? And we know which patients are not going to have a good biopsy. So the AUA, our urologic guidelines, say biopsy always in some patients if you think it's a metastatic disease to the kidney. And if a patient is young and healthy and they would never accept the uncertainty of a biopsy, don't biopsy. But there's a gray area which if patients want additional information, we can give it to them. Okay? So a small amount of tissue is able to be taken from a biopsy. The most common benign tumor, however, resembles the third most common type of kidney cancer. Fortunately, when a pathologist is not able to distinguish between benign and that third most common type of kidney cancer, it's generally a very wimpy or indolent kidney cancer. Okay? So pathologists, they really now only give information on shape or what we call morphology, but they can give some insight on the aggressiveness on a biopsy. Okay? But now we have all these methods to genomically characterize mutations, copy number alterations, and that's an area that I've worked in for many years now to understand the molecular genetics of kidney tumors. We have 18 types of kidney tumors. I explained to people there's many flavors. We have our Coke and Pepsi, but we have other types of colas that we can drink. Okay? And it may help us distinguish these genetic markers into the good, the bad, or the ugly small renal tumor. This is one example. This is while I was at Yale in their newsletter. This patient was facing dialysis. He had a large tumor. I biopsied it. The pathologist said, cannot rule out cancer, may be benign. This is what we call the oncocytic renal neoplasm. I did genetic assessment of his tumor, and not with 100% certainty, but with, I would say, 95 to 99% certainty, were able to reassure him his tumor was likely going to be benign. He did not have surgery. He did not go on dialysis. I call that a success story. Okay. Now we have a trial that we're going to lead that will initiate really what is the role of a genomic or enhanced biopsy, where half the patients get this new enhanced genetic biopsy, which is currently not reimbursed by insurance. Is this able to give us more information, better counsel patients, and allow the patient and the physician to have shared decision making and not treat every tumor like it is going to be a lethal tumor that must be radically treated? Okay. Now what about imaging? Finally, I'll touch on something I'm very excited about is, can we do better with our imaging to give you more information about tumors' behavior? So there are functional imaging from things, which we call functional imaging from nuclear medicine scans. And we have these in other cancers. We've had a webinar on PSMA Dr. Reiter gave. It's a not FDA-approved indication yet, but we expect that hopefully will be coming. But they're ways to detect small volume metastatic disease in prostate cancer. We have a PET scan in many cancers, okay, which you can look at uptake of sugar. Tumors have a sweet tooth. Are these useful in kidney cancer? Not really. But are there other nuclear medicine tools that can help us distinguish about renal tumor biology? This is a type of scan called a sestamibi. It is used in the parathyroid world to localize a tumor in the neck. It is a common nuclear scan, and it picks up tumors that have a lot of mitochondria. There are two types of kidney tumors that have a lot of mitochondria. One is a benign tumor called an oncocytoma. The other is the one that on a biopsy it's hard to distinguish between cancer and benign, but it is a pretty wimpy kidney tumor, and each year only a handful of patients in the whole United States would die of that type of tumor. Most of these are incredibly wimpy. So UCLA is one of the only centers in the country, other than really our colleagues at Johns Hopkins, which are doing this scan, and we think it can give more information. So for this one individual here that we said you have a 71% chance of doing the tumor, having the tumor be cancer. If you had done this scan and it showed it was suspicious for cancer, this bumps up to 90%, and it would be 50% if it was considered suspicious for benign. But the other 50% are generally pretty wimpy or indolent tumors. Is this sufficient to change a patient's mind with the uncertainty or the doctor's recommendations? We're not sure. So this is a trial that I put together. It just opened this week, where we take patients with small renal tumors, we do the scan, we counsel them with more information, and we see if that information will change what they want to have done with their tumors. Again, this is a shared approach between the physician and the patient. So finally, in conclusions, we have a tremendous explosion in the number of kidney tumors found each year. Okay? Many of these are benign or indolent. Again, 8% of our kidney cancer operations in the United States are for benign tumors that are really unnecessarily performed. Okay? And even the cancers, the majority of these small tumors were indolent, and really I would call their treatment over-treatment. And we have other options available, such as surveillance, or even this needle ablation or cryoablation technique, which would be less invasive and quicker recovery. Biopsy is safe. It can provide some insight. We have nuclear medicine tools that we have at UCLA, which we have this protocol we're very excited about, and it's available right now. This enhanced genomic biopsy is something I'm pushing the field forward. We'll have a trial, or we'll try to integrate some of these molecular biomarkers at the tumor level, looking at the genetic changes to look to see which tumors are good, bad, or ugly. Okay? More information is better than less information, I believe, in any time, any type of disease. Okay? And we can risk stratify tumors to really help you make the decisions. Okay? Thank you very much, and we'll now open up questions to our millions of viewers at home. Okay, so a couple great questions. So the first question we'll kick off on what causes renal tumors. That's a great question. we have a lot of different things which can contribute to tumor development. It's very hard to tell an individual patient who's sitting across from you and say, this is the cause of your kidney tumor. However, there are things such as genetic predisposition. We know there are several genetic alterations which give you a really higher risk. Some of these are genes, such as you've heard of the BRCA gene. It's not relevant in kidney cancer, but we have about 15 other kidney cancer genes which can be passed. We also know that there's strong inheritance, just like you inherit genes for eye color, genes for being obese. We have several things which can slightly predispose somebody's risk. Men get kidney cancer twice as common as women. Things such as being obese, having high blood pressure, having renal disease, smoking, okay, all those can increase your risk of developing kidney cancer. A lot of those are modifiable. Okay, so I'd say exercise, try to lose weight, watch your blood pressure, okay, and then you can try to lower your risk of developing kidney cancer. So what are the chances of a tumor spreading when watching it? Well, watching it with active surveillance is not for everyone. Okay, we would not watch a gigantic tumor which had symptoms. But for many of these small renal tumors, in the select patients, the risk of it spreading on surveillance for patients who are too unhealthy to have anything done is about 1%. But when we have the ability to watch it and offer delayed intervention if necessary, I would argue that risk is far lower than that 1%. But again, you need an experienced doctor who feels comfortable and giving you all the available data and tools to help follow the appropriate patients. Can tumors come back after treatment? That is a great question. Okay? I really find it really disturbing when a surgeon goes to a patient and say, I got it all, you're cured. Unfortunately, with tumors or cancers, biology is destiny. If you have an aggressive tumor, even if the imaging does not show that there has been any spread outside of the kidney, you never know. We have no ability to image a single cell. So sometimes we do a surgery and we are convinced there's going to be no chance of spread. And then 5-10 years later, a tumor comes back and you're shocked. Other times, for these nasty, aggressive tumors, you remove the whole tumor, and you're really worried that the tumor has a very high chance of recurrence. You follow the patient incredibly closely, and it never comes back. So we need to do better at really understanding which patients are at highest risk, and we are doing trials with some agents which we hope will lower the risk of recurrence in patients who have a very high risk of recurrence. Because right now the standard of care is really watching patients closely and just hoping and monitoring. Okay, so with no other audience questions, we'd like to thank you for tuning in to our UCLA MD chat, and we'll look forward to educating you in the future. We'd love to have any patient with kidney cancer in the region come visit us, and we'll give you the most up-to-date kind of tools that we have available in our UCLA Kidney Cancer Program. Thank you very much.